Hello, everybody. Firstly, I'd like to thank the British Journal of Surgery Foundation for their kind invitation to give this talk, and to Katie Pearce for her expert help in producing it. I thought it might be interesting to consider the practice of mainly surgery and medicine in Britain's Royal Navy in the pre-anaesthetic and pre-antisepsis era 2 centuries ago. Because soon we commemorate the epic Battle of Cape Trafalgar, which happened 220 years ago on October the 21st of this year. During that action, which placed Britain at the very pinnacle of its sea power, during the 23-year war against Republican and Napoleonic France, the nation paid a high price for her success as she lost the iconic, interesting and notable commander, Rear Admiral Lord Horatio Nelson. I would also like, therefore, to incorporate a few words about his career injuries and his death during that latter action. To anyone in the audience who isn't medically trained, I should add there are a few challenging images which do reflect contemporary traumatic issues. This war, being longer and more extensive than the preceding 7 Years' War, was really the first world conflict. Remarkably, as we look at the locations of the principal Army and Navy actions during this war, we have to recall that all transport, either in supply, patrol, capture or conflict, was by wind-driven vessels. And over the 23-year conflict, Britain lost a greater proportion of her population than in the 1914-18 war, and incurred a massive national debt. It's interesting that in 1814, the Royal Navy had over 700 ships, while in 2025 it has 52 surface vessels only. Life in the Navy was tough. There is little doubt about that, but it could be perhaps a little more pleasant when you're cruising in a frigate off in the Caribbean waters and perhaps taking prizes and making some money in doing so. The escort of convoys in the war was tedious for the Royal Navy because the Navy had to go at the pace of the slowest vessel. And perhaps one of the most arduous tasks was when the Navy had to blockade enemy fleets and keep them in their own ports and stop them breaking out. And of course, when there were major naval actions, the trauma was significant. Now, it's interesting to comment that over this war, a total of just over 100,000 Marines and sailors died, and over 90% of these died from disease, accident, shipwreck, fire and explosion. And in fact, only 6% died as a result of enemy action. And this underpins what a tough life it was in the Navy. In the film Master and Commander, starring Russell Crowe as the captain, there was a relationship which was perhaps a little unusual between the doctor and the commander, but it was important where you had a good commander that you also had a good surgeon, because together they would care for the health of the ship as best they could. The ship's surgeon had to be not only a surgeon but physician, a dispenser of medication, a confidant, a public health advisor with regard to food and its quality. The provision of service surgeons was certainly more generous in the British Army, who had roughly one surgeon for every 250 soldiers, whereas the Royal Navy had to have a surgeon on every type of ship and a varying number of mates. So they had a surgeon for every 100 or so sailors and Marines. Most ships had a surgeon, therefore, but there were a varying number of mates or assistants. We talk about rating when we talk about Royal Naval ships. First rate was 100 guns or more, second rate 84 or more, and so on. The commonest types were the third rates and the frigates, the 6 rates. But of course, at Trafalgar, we are reminded that Surgeon Beatty only had 2 mates, not 5, as he should have done for a first rate, because, as in the army, often doctors were sick, absent, or there was a failure of recruiting. Now, the training of a surgeon was that of basic schooling till about 15, and then your parents or relatives paid for your apprenticeship for about 5 years, And then you walked the wards and attended further lectures and dissections and so forth. And then you took an examination, which gave you a diploma. And in wartime, the diplomas were a sort of emergency measure. The MRCS could be taken in London, and in Edinburgh, the FRCS, or in all of these, an MD rarely could be obtained at an early stage. Then the candidate would go to be a hospital's mate or assistant. This was only a warranted rank until 1805, and then they had proper commissions as officers. And then you went on, if you were lucky and survived, to be a ship surgeon or a staff surgeon or physician in hospital. Now, obviously, one had to study as an apprentice and as a pupil, and there were far too few cadavers, as shown over here, for public dissection. As part of the execution penalty was to be publicly dissected, so the practice of grave robbing was fairly common. Many of these grave robbers were actually ex-servicemen too. And then schools of anatomy, there were about a dozen in London, for example. Here we can see William and John Hunter feverishly dissecting a corpse and teaching on it during the spring and autumn months. There were other aids to teaching, obviously wax models, and here's a wooden cranium down here used for the practice of trephining. If you look at the Royal College of Surgeons of England's coat of arms, you can see that it incorporates in the centre 2 anchors and 2 portcullises, respectively denoting the responsibility the college had to its students. And in fact, there were other responsibilities for the ship surgeon. Through the college, they had to, for the sick and hurt board in the Admiralty, they had to produce ship's logs. So here's a log listing an injury and operation on Nelson in July 1797. Under here, you can see minutes of the Court of Examiners at the Royal College of Surgeons, admitting down the bottom that Lord Nelson had or Admiral Nelson had an injury relating to the loss of an eye, and that would, loss of an eye or loss of a limb, gave a fairly generous pension to these officers. And also, of course, the Court of Examiners had to approve the set of instruments that were taken on board. After the surgeons had broken away from the barber surgeons of London, they became the Company of Surgeons, and there was a building erected near Newgate Prison, which was destroyed in the Second World War. But eventually in 1800, work began on the Royal College of Surgeons of England in Lincoln's Inn Field, and in 1813 it opened its gates to candidates during the war. The Royal College of Surgeons in Edinburgh, with its Playfair building, is shown in the middle, and at the bottom left you can see the Royal College of Surgeons in Ireland in St Stephen's Green. On the right is a histogram showing the number of candidates taking the certificate, the military or naval certificate in surgery, rather than the MRCS, which are the blue blocks. And you can see that during the war years until 1815 on the right, far more people took the emergency exam. And you can also see that around 500 a year surgeons were being let through the portals into practice. The examination was merely an oral exam. You can see the candidate nervously standing on the left, and after checking the credentials of study, he would be given, if suitably qualified, a certificate. You can see that on the right here, actually promoting somebody to go and serve as a surgeon in a regiment rather than a ship, but that was the surgical exam. There are about 10 examiners, and the sort of questions you can see on the left here, which is taken from an 1815 crib book. What are the terminations of inflammation, resolution, suppuration, mortification, treatment of gunshot wounds? They're fairly basic questions. Then the candidate for the Navy went to the sick and hurt board in the Admiralty and got a certificate after being quizzed on medication and management. And they would appoint somebody as a first, second, third or fourth mate to a rated ship. And this candidate here in 1781 was appointed as a first mate on a first-rate ship, HMS Cumberland. Then he went off to sea. And there, the junior surgeon, the mate, as he was formerly called, was introduced to the cockpit down in the orlop deck just above the bilge, a pretty noisome, underventilated, smelly area, and he shared his quarters with junior warranted officers, the surgeon and a dispensary and many stores and so forth. So not a very auspicious beginning for the young person. Before 1805, nothing to do with Trafalgar, but there was no commission, just a warranted officer below wardroom rank, no decent uniform, not very good training, inadequate allowance certainly for instruments, and accommodation was not brilliant. Various reformers, Trotter, Lind, Gillespie and so forth, improved all this gradually, and 10 years after the army, the Navy got equivalent ranks and pay, and the mates were renamed assistants, and although they had to purchase their own instruments, still their uniforms were provided. What about improvements in health in the Royal Navy? Well, by this time, by 1805, again, lime juice and lemon juice were known to prevent scurvy and were taken compulsorily on board ship. Smallpox by Dr. Jenner's variolation or vaccination had been a success. And the diet had improved somewhat, very basic and dull, but with plenty of calories. The hospitals had improved their results. There was increasing experience as the war went on. And as mentioned, the conditions of service for the surgeons had improved and for the sick. Interesting to see that in 1780, before the war, there was a 1 in 8 mortality as opposed to 1 in 30 in 1812. So there you have distinct improvement in results. This is James Lind. He was a senior physician in Haslar Hospital, of course, and you can see the mild and severe appearances of oral scurvy. Nelson, in fact, on the North Atlantic station did have an attack of scurvy and lost some teeth. And here is Dr. Jenner with his, you can see in the early the 20th century, you can see a victim with variola major, a very nasty injury indeed, disease indeed. And of course, as mentioned, the life at sea was tough, with inadequate clothing and frozen hands, taking in heavy wet canvas or clinging on to spars and rigging demanded extreme strength, and many men were lost in accidents in this way, and heaving huge barrels or 2-ton guns around led to dislocations and rheumatism and bruising and so forth. As for diet, well, every man on board ship, for instance, the Victory had a crew of 800, had a pound of bread and a gallon of beer every day, including the younger people. And you can see that 4 times a week they got meat, pork or beef. And then on the right, you can see for the other days, they had to make do with peas, oatmeal, butter and cheese. And meals were taken by gun crews of 6 to 8 men, on square plates with rims to prevent spillage, hence the term square meal. And on the right, you can see a wheat and flour and water made biscuit made at the Royal Clarence dockyard. The calories per day for this regime were necessary, particularly for topmen and gunners in action, and they gave more than 4,000 calories a day. And here's a gun crew. One of them would be designated to go and dip the meat for a given time of water, time to dip the meat in boiling water, and the 8-pound chunk of beef was then sliced up and given per crew. There were, of course, civilian problems on board, the appearance of a hernia, which was only repaired in an emergency, hydrocele, which could be tapped, prostatism, could be catheterization, but no definitive cure, and a urethral stricture. And here you can see a stricture in John Hunter's book on venereal disease, which would be dilated or treated wrongly by caustic. Bladder stones could be removed, but only on shore with major surgery. And sprains, fractures and arthritis, as mentioned, had to be managed. There were not a few suicide attempts on board. 1 man, or 2 men actually, had successful repairs of their trachea in an awake state by naval surgeons. Here we have a wax model by Charles Bell showing the sort of incision made for an inguinoscrotal hernia, but often strangulation was a fatal problem. Fractures, understandably, were not uncommon in the Navy because of falling rigging and falling down companionways and heavy weights falling upon men. And these were not managed well. I mean, if they were tightly bandaged and immobilized, you could get terrible pressure sores, and mal and non-union and delayed union occurred, as did with short splints as used here. I did find in one French book a ingenious contraption used by the French at the end of the war, whereby the whole limb was immobilized, stabilized, and had a tiny bit of traction applied. But it would be another 100 years before the appearance of the Thomas splint. So here are some instruments used for extraction of bladder calculi, which is done usually through the perineal route, catheters made of gum elastic or flexible silver, tubing, and also bougies for dilating strictures. If you couldn't get into the bladder with a catheter, you could always use the suprapubic route. The indwelling solid catheter was held with tapes and was made of silver, but obviously this would not last the patient very long. Burns were not uncommon at sea and with explosives and fires and so forth, and were treated with coolants, analgesics, and often a solution of lead acetate or opium ointment. But the problem of sepsis and massive fluid losses were just not appreciated. Here you can see a full thickness burn, which would just be left to scar up in due course. The mildly hurt and sick were cared for under the forecastle on the starboard side of the ship, where they were nursed in cots rather than hammocks. And here you can see a water supply in the area of the sick bay, and also a medicine cabinet and an operating table above a gun, and the door through to the heads. There were just on first rates, there were just two heads forward by the bowsprit, where people could egress and have their bowels open. This is just to show you about sickness at sea. Here we have a large French frigate patrolling the Mediterranean, and you can see across 3 months that there were 4 deaths. One of them a woman, interestingly, because there were women on board most ships, officers or warrant officers, wives or master gunners and so forth, and they would help with various obvious tasks on board. The total number of sicknesses presenting to a doctor was never more than about 20 on this voyage, and new cases of no more than 5 a day. But you can see that there's always a 10 to 20% sick rate amongst the crew. Hospital care, well, there were base hospitals at Plymouth and Yarmouth, and of course Haslar, which was at one time the biggest brick-built building in Europe. Only 3 sides of the intended square hospital were ever completed, and it was on loan to the army on occasions as well. But this was a great development in hospital care for the Navy. Old warships were transformed into hospital ships, and you can see that there's an ague ward for malarial sufferers, an itchy ward for scabies, a ward for dysenteric patients, and a fever ward for those with febrile illnesses. All these little squares off at the side of the ships were nurses' stations, but you'd find a hospital ship on most convoys and expeditions, often more than one. But with the coming of war, things were different. What we're looking at here is a first-rate 3-decker HMS Victory sailing in light airs, a great painting by Geoffrey Hunt. And here you have a vessel which sported 100+ guns, which was a greater complement of ordnance than was on the field of Waterloo for the British Army. So they are hugely powerful instruments of war. And things were pretty crowded on board, with a crew of 800 necessary. On board, on the top deck, there were splinter nets to stop some debris falling upon the heads and bodies of the seamen operating the upper gun deck. but it was a very risky pace from falling debris and recoiling cannon and so forth. And you can see here behind Lord Collingwood, who was second in command at Trafalgar, there are nets that contain rolled up hammocks to protect crews on the upper deck from round shot and splinters and so forth. And of course, the other risk to the exposed men on the upper deck was those from sharpshooters in the foretops, which were often screened off, and they could throw grenades or shoot individuals when their vision was good. Below decks, you were also at risk because large pieces of iron could smash through the decking and cause splinters to fly off. And it was, again, a very unpleasant, hot and challenging environment. Here you can see some gun crews in action. When somebody is wounded as a first aid measure, and about 10% of the naval ratings were supposed to know how to put tourniquets on of one sort or another. You can see a couple of examples here. But what was important, apart from stopping bleeding, was to cover the wound with adhesive plasters, sutures, and dressings. And the victims were often very thirsty. The wounded had an immense thirst. And this is a military canteen which contained about 1.3 litres, which would be given to men who were hurt. The problem with the Royal Navy was that badly injured officers and men and Marines could very quickly reach their surgeon below decks. Here you can see Nelson being uncomfortably manhandled down a companionway to the orlop deck. But of course, these people who are arriving badly hurt, fatally injured, possibly the surgeons could often do nothing much for them, as was the case with Nelson. Whereas in the British Army, the injured often were far distant from their surgeon and surgical aid, and therefore they often died before reaching the surgeon. This is a deck plan of the orlop deck, where there are cable tiers, stores, the captain's store, the surgeon's cabin. He was right down on the bottom deck, even the surgeon, and a dispensary, and some various bits of equipment. But this little area here with the red crosses was the cockpit. That's where the junior officers hung out, and here the surgeon would perform his surgery. But of course, the whole deck was often swamped with injured people. Here again, in cross-section from a French book, you can see the position of the orlop deck above the bilge and below the lowest gun deck, where the 32-pounders would be hammering and recoiling and making a hell of a lot of noise above the orlop deck. Instruments, well, here we can see in the top left, the Duke of Rutland was sent this set to compensate for the loss of his son back in 1781 at the Battle of the Saints. So this is a naval officer's, medical officer's kit. You can see trephines and amputation knives and parts of saws and ligatures and so forth. And here we can see Surgeon William Beattie's kit, which is far more efficient, with 3 handles serving 6 different screw-on attachments, such as blades and saws, chisels and so forth. You can see a petit screw tourniquet here. And here, bottom left, is a presentation assistant surgeon's naval case from 1808 with thumb lancets, bisturies and scissors and probes and so forth. And this is a picture of William Beattie, who was to manage Nelson in his last moments. Surgery was often performed in the upright position because ergonomically, and sitting on a sea chest or a chair, the surgeon could move around the patient with considerable ease. And here we have a patient about to go a disarticulation at the shoulder without anaesthetic. One of the assistants is compressing the brachial artery here. And here we can see another assistant holding the patient in case he faints, as he almost always did, and the surgeon awaiting to proceed. Battle surgery. Well, the injuries caused were obviously metal strikes by round shot, many injuries by impregnated splinter wounds, impregnated with bacteria and blood and filth and other fluids, small arms fire, cutlass and hatchet injuries, piercing injuries with pike and dirk and so forth, and of course the civilian types of injury of drowning, fractures and so forth. Here we can see a unusual picture of a burst cannon breech, which was a very rare injury, but often would kill the whole gun crew. I looked at, on the left, you can see the French and British Army injuries. There are over 700 individually looked at here. These were surviving patients, and 62%, almost 2/3, were caused by small arms fire, the injuries, and about 17% by round shot cannon fire. Now that was reversed. If we look at 100 odd patients from the French Navy from the Battle of Trafalgar, we can see that 58% of injuries were caused by splinters more than round shot. Of course, the splinters were caused by the round shot, and we have also 13% caused by small arms fire. So there was a different type of injury in the two services. Here you can see from Fort Niagara, from a medical waste pit, the right femoral shaft has been shattered by a round shot, and these were large lumps of iron moving actually fairly slowly but carrying enormous kinetic energy. The only way of surviving them was, in fact, if a limb was avulsed. Here you can see a man with his arm torn off by a round shot, or if there was a tangential injury, striking the body at an angle and causing damage, in this case on the right, with fractured ribs and bruising. And both of these men survived their round shot injuries. Here you have a round shot as seen, and before we go on to other types, you can see the anti-personnel missiles here. Canister was largely used in the Army and grape shot in the Royal Navy. And we have different types of bar shot, chain shot and so forth. These were often used, and red hot shot, to either set a ship on fire or damage rigging so that you could slow it up and take the ship as a prize. That was a French tactic. We tended to just beat the hell out of ships with round shot to destroy them and their crew before we took the prize. This was a double-headed bar shot from a Spanish flagship at the Battle of Trafalgar, killing 8 Marines standing not far from Nelson. It was presented eventually to Queen Victoria and is at Windsor Castle. Head injuries, well, there were various, obviously depressed fractures, slicing injuries, musket ball injuries, as shown here. Both these patients actually survived, but obviously something had to be done for those who had depressed fractures, which was a common injury. Here you can see top left a depressed injury in a skull, and what was required was the trephine with its saw blades to make an incision on a fairly stable bit of skull near the injury, and then the bits could be elevated and lifted out, and often symptoms were relieved. And sometimes hematomas were obviously evacuated and fluid collections. You can see various elevators and saws and forceps for elevating the disc of bone here. Sadly, many of these cases ended up septic with the so-called cerebral fungus, which was an overgrowth of infected brain, which often resolved or sometimes needed excision. Chest injuries were not uncommon, and many men survived, obviously peripheral injuries, not through the great heart and vessels, but through and through, or non-exiting chest wounds with pneumothorax as hemothorax, as would not the case with Lord Nelson for other reasons. And the patients would often be laying on the side of the injury and their wounds, injuries bound up. Sometimes a trocar and cannula were passed in to relieve tension of air or blood and fluid. Abdominal wounds were often fatal with bleeding and sepsis, but this is a superficial one passing around the anterior parietes. And unfortunately, the musket ball often carried clothing with it, with its bacteria, and so necrotizing fasciitis, hospital gangrene would occur in such wounds, as in a modern case seen here. This man has had an extruded greater omentum and transverse colon following a sword penetrating injury, and part of his colon was gangrenous, so was removed, and he would have ended up, and he did survive, with a colostomy. But how they managed his motions and the dressing without modern stoma care, one has to wonder. This is, by contrast, a World War II stoma, much neater, made after a gunshot injury. Small arms wounds could cause a huge variety of injuries. On the top left, you can see a man hit by a musket ball, and it's wounded his profunda femoris artery, and he nearly underwent amputation, but managed to avoid that as the bleeding eventually stopped. This man died of a tension chylothorax, and this one here, apparently with a shoulder and head of humerus injury, the ball had actually passed into his lungs and he perished. Now here we can see a man who's had a trephining with the fungus cerebri set in, and he shows the typical Hippocratic facies and will not survive. The missiles, when these top ones are retrieved from victims at Waterloo, the top 4 dark ones are obviously canister rounds with very little indentation or distortion, which is in contrast to the musket balls, which often struck bone or belts or buckles and deformed, causing a worse injury than a smooth ball. Here you can see little fragments of clothing which have been driven into wounds which carry the infection deep into the wound, because of course sailors and marine clothing was not clean. Often the surgeon explored the wound digitally or opened it up with a scalpel, and then he would put in various types of bullet extractors, such as this Coxeter one here, or probe it. Probing was difficult because you didn't know whether you were hitting bone or a ball, but then the finger, if it felt the ball, you could pass the forceps down alongside it and retrieve the missile. In general, with soft tissue injuries, primary closure of contaminated wounds was a great mistake. This is actually a photo from the First Iraq War. It was performed, I'm glad to say, not by a British surgeon, attempt at closing a dirty wound. And these 2 bottom pictures show shrapnel injury from the First War, and it shows you the extent of primary wound excision that needs to be carried out to prevent sepsis. All dead and dying muscle, and it may take several sessions, has to be removed and the wound left open to be closed later or grafted. Amputation, well, obviously converting the left-handed injured limb to a neat stump was something that, in military terms, the sooner it was done, it was better, because it was easier to transport a man with an amputation stump than with a comminuted, exposed and dirty wound. The type of amputation carried out did vary a little. At the beginning of the war, the circular guillotine amputation performed with curved blades, as shown above on the left here, with 2 sweeps of the knife, one through superficial integuments, the next through muscles, was replaced by the flap amputation, which happened during this war, whereby a straighter blade was passed through above and below the bone and eased out at an angle to produce a flap which would cover the bone ends far more efficiently than the guillotine amputation. Saws to divide bone, this is a continental saw. These tended to be less efficient than the British Tenon saws, which were more robust. These blades tended to snap. And here you can see some smaller saws, a petit screw tourniquet, and some bone nibblers to trim amputation stumps. So when the tourniquet was put on, the patient was supported and the 2 sweeps of the blade made. The soft tissue tissues were retracted and the bone was divided, and then with some difficulty the wound would be closed in this type of amputation. Sometimes the bone splintered before it could be properly divided, but cutting the skin and dividing the bone were the most unpleasant bits for the patient. Here you can see a tenaculum, which is a mounted sharp hook being passed through the mouth of a vessel to ease it out so that silk or linen ligatures can be applied. Down here at the bottom, you can see ligatures are left long after the amputation to be removed on the 12th to 14th day. And there is a Malta cross bandage stump following completion of the amputation. Obviously, the surgeon would release the tourniquet before closing the integuments so that he could see that all bleeding was controlled. By and large, veins were not ligated, only arteries, and this probably speaks for the hypotensive state of the patient. It's interesting if you look at the Battle of Waterloo, which is not far from Trafalgar, as it were, in time. Therein, the red bars are from that battle, and the Crimean War 40 years later, when there was anaesthesia available. You can see that this histogram shows that the mortality in green from the Crimean War was by and large greater than those from 40 years earlier, which meant that, again, experience and judgment of when and where to do which operation and how well it was done gave better results at an earlier stage. Now we talk about Nelson and his wounds. His career was peppered with injury. The nature of the man was to be first on board where possible, leading the attack. He liked to be thought of as a hero, and he was indeed a very brave man. And this wax figure, which is still maintained, I believe, at Westminster Abbey, is a very good likeness of Nelson, according to Emma Hamilton when she saw it. Down in the Mediterranean, off Bastia, off the north coast of Corsica, off Cape Corse, Nelson had to land some naval guns to help batter the citadel at Bastia into submission. He did this, but a shell from a French gun thumped into the earthwork beside him and knocked him backwards. He had a small cut on his back, and it was hardly noticed. He mentioned it in some letter to somebody, but he never told his wife, Kitty, about these injuries at this time. Then a more serious injury, not in April 1794, but in July of the same year, when he'd again brought guns at great effort up to batter the citadel at Calvi on the other side of Cap Corse in the north of the island. And again, a French shell hit a parapet and knocked some splinters of stone into his eye. And he was certainly temporarily blinded completely. He bled profusely from multiple cuts, had hyphema and a very painful eye. And in fact, reading between the lines, and there's been a lot of research done on this injury, he could really only define light and dark in his right eye. So to all intents and purposes, he was blind. He never wore an eye patch, according to several accounts, but here you can see a little green shade sticking out, tucked into his bicorn hat to keep the sun off his eyes, because he gradually did suffer with cataracts and poor vision due to his long-time weather exposure. Here is Commodore Nelson, 1797, boarding a Spanish ship which had collided with another, and he took them both captive, off Cape St. Vincent in February of 1797. And a nearby shot hit a wooden block, such as this one here, and the splinter flew and hit him in the right lower abdomen, just above his groin, and he had a tremendous hematoma. Also, he had transient suppression of urine and went into retention, but that was relieved, presumably bruising of the bladder. And the muscle weakness engendered from this injury caused him to have a hernia the size of a fist, which he had, was painful intermittently, and he kept reduced with a binder. Hernias were a reason not to be in the Navy, but of course they occurred as an emergency not infrequently. And when you see a picture like this, a drawing by Charles Bell, you can see a probe being introduced to the constricting ring, which is then divided with a knife. And then the wound was closed. And of course, the hernia would recur because it hadn't been definitively repaired. On the right, you can see a selection of trusses worn for patients not in service, but it's interesting that the London Trust Society in, I think, 1794 stated that around 14% of the male population of Britain suffered with a hernia. Well, the next injury was in July of 1797 when Nelson was given permission to take a squadron to Tenerife to capture some prize ships and take the town and the island. Unfortunately, they knew we were coming, and the combined operation series of boat landing and marine sailors failed. And as Nelson was about to disembark from his small boat, he had a shot through his right humerus, which was bleeding profusely. And his stepson, Lieutenant Josiah Nisbet, who was in the same boat, took off his neck stock, tied it around the arm as a tourniquet, and they rowed out back to Nelson's ship, the Theseus, and picking up some survivors from a sunken ship nearby. So the whole expedition was a failure. Nelson knew that his arm was shattered, and he struggled up the tumble hone of the ship with one arm and two legs, calling out for the surgeons to get their instruments ready because he knew what had to be done. He bore the amputation with fortitude, and when asked what was to be done with his limb, he said, "Throw it into the hammock of this poor chap who died beside me." So sailors were buried in their hammocks when they were killed. And Nelson got through this. He had 3 doses of morphine, as far as I can tell. That was the only pain relief. And he was very depressed about this injury, and his arm stump, or flipper as he called it, remained very painful because median nerve lying at the site of operation very near to the artery, part of it had been included in a ligature to tie off the vessel. And it was only 4 months or so after surgery that he was able to be free of pain when the ligature came away following a septic episode. And you can see with the eye of faith from this Samuel Lemuel Abbott's portrait of Nelson how gaunt and possibly pain-ridden his face remains. Anyway, he recovered from that to lead an expedition against Napoleon's naval force moored off the North African coast, not far from the Nile. French had landed troops in Egypt to capture that country, to interfere with British trade to India. And over the 1st and 2nd of August 1798, Nelson, and you can see his ship bearing down here, HMS Vanguard, on the line of French ships moored up. And with brilliant tactics, they battered the French fleet and into submission, capturing all but 2 line of battle ships. But about 8 o'clock or just after, his forehead was struck with a piece of langrage or scrap metal fired from a French gun, and he fell back into the arms of his flag captain, Captain Berry. Was taken below deck. And this height of this orlop was much exaggerated, but here you can see, and actually he's had his right arm put back on again. The painter has painted out his wrong amputated limb. But anyway, what it does show is Nelson being tended by somebody down on the orlop deck, holding the wound, and he's been given some fluid to drink, probably water. And Surgeon Michael Jefferson put some sticking plaster adhesive tapes on the wound. The bleeding stopped and he had his head bandaged. On the right, you can see a surgeon about to remove a leg on a sailor with the instruments scattered on the floor and the sailor being restrained. He went up on deck. At about 10 o'clock, he witnessed the explosion of the French flagship L'Orient. And in a painting by Guzzardi, a year later, with the eye of faith, you can see an inverted Y-shaped scar here. And this was a flap of skin that had fallen down over his eye because he thought he'd been blinded initially, which had been put back into position. This head injury caused Nelson quite a lot of problems. But anyway, he lived on to fight his last battle and incur his last and fatal wound, the Battle of Trafalgar. Many of you will know that the fleet, enemy fleet, which was slightly larger than our own, combined Spanish and French ships, and sailing north from the windward side, Nelson divided his fleet into 2 squadrons to break through the line, breaking it into 3 parts, the front of the line being isolated really from his assault, and Captain Collingwood taking the Lee squadron got engaged a little bit before Nelson. And Nelson actually crossed the line at about 12:30. He crossed between a ship called the Redoutable and the Bucentaure, which was the French flagship. And we can see here, as he approaches the line, the Temeraire attempts to overtake Nelson's ship, but they're told to get back on station. Nelson was going to lead in his characteristic way into the windward squadron assault. These little ships, boats tied behind the ships, show you how they would pick up survivors who were in the water during the battle. The 21st of October then, at 12:30 odd, the Victory passed between the 2 French ships and let fly at least a ton of iron down each ship with a rolling broadside as it passed between the ships. The Bucentaure suffered about 20 guns dismounted and over 200 casualties with 1 broadside. It shows you the firepower of these ships. And you can see here top men ready to shoot down any Frenchmen on deck after the Victory had passed through into the line and engaged. And it was moored up next to, got entangled actually with the Redoutable, had a very brave French captain. And about 3/4 of an hour later, while they were pounding each other, and you have to remember that this British gunnery was probably 2.5 to 3 times faster and more efficient than the average French gunners, were pounding the Redoutable to bits. A shot rang out from the mizzen top of the Redoutable, and a sharpshooter had shot down Nelson, whether by chance, because it was very smoky, there was movement of the ships, one doesn't know, and the marksman has never been identified. But Nelson was struck down on the quarterdeck, and he was hit at an angle to vertical of about 43 degrees and about 15 degrees off the lateral. So it was fired laterally, it went through the region of his left shoulder. And this pictorially is what happened. The shot clipped the tip of the acromion, broke the 2nd and 3rd ribs, entered the chest, causing a hemopneumothorax, passed through the lungs and smashed between T6 and T7, and the ball came to rest under the right scapula. That was the nature of injury. He covered his face with a handkerchief so as not to be recognised, and was struggled down to the orlop deck, where Beatty came at once to see him. And he admitted that his life was over. He knew his back was shot through. He'd witnessed a sailor fall from the mainmast of Victory during a tour of the Atlantic, and he knew he had spinal paralysis. Here is Nelson's coat at Greenwich now, with the shot hole and far too much epaulette missing, because a lot of that was torn off when it became adherent to the blood-stained scalp wound of a young midshipman lying next to Nelson. Nelson's coat was used as his pillow. But a few bits of epaulette did get in. You can see little strands of it here. This is a rare picture of the actual ball taken out of its case. It's now exhibited in its case at Windsor Castle. You can see it flattened by the spinal hit and distorted. And it was presented to Captain Hardy, who gave it to William Beatty, Dr. William Beatty, who later was knighted for his part in the action and later presented back to the Queen. If we look at energy expenditure from modern and old weaponry, here we have energy plotted against range, and you can see that the SLR, SA-80, AK-47s have got really considerable power and impact over distance. Whereas if we blow up this little bit at the bottom here, we can see that the flintlock muzzle loading smoothbore muskets were much less powerful. But Nelson was shot at 23 meters, so if we extrapolate that to energy, he has had a wound that impacted with 200 joules of energy, which is enough to shatter a thigh bone twice over. Of course, there was no cavitation as seen in modern wounding, except with very close-up injuries. But anyway, this shot was directed straight on. It wasn't deviated by bone, and it had enough power to get through the spinal column. You can see a side-on picture of what happened in the chest, and here also the two segments of the left lung, which were traumatized. When Beattie opened the chest, he was quite surprised that there wasn't more blood than appeared. And Nelson had taken 3¼ hours to die, and he claimed that perhaps a branch or the main left pulmonary artery had been severed by the ball. But actually, if you measure the angle as given, it was probably a shot that passed behind the main pulmonary artery. And there were many examples of such non-exiting chest wounds and exiting ones, as I've said before, that survived this sort of injury. Well, we have to explain what happened here. And it was the fact that because the spine had been shattered and the spinal cord damaged, the autonomic nervous system had been destroyed, and therefore the ability to compensate for a medium-sized, fairly heavy blood loss had been obliterated. And therefore, Nelson did die of hypotension and blood loss, but as a consequence mainly of his spinal cord division at T6. As he lay dying, and the artist has very correctly left out any injury to his left shoulder region, we can see the Reverend Scott rubbing his chest from the referred pain from his spine, two servants looking anxiously on, Captain Hardy looking over him, and Surgeon Beattie taking his pulse. When people ask why Hardy kissed Nelson, which he did twice, and Nelson requested him to do so, it's interesting that you think he's dizzy from the loss of blood and hypotension. He's got no right arm. He's got no sensation below the nipple level, and he must have felt very isolated in a physical way, and perhaps being touched by another human being before dying was almost a normal request. His body was placed in a leaguer of brandy, and when they reached Gibraltar, the ship was towed in by HMS Swiftsure, and the body was immersed in brandy, as I've said, and then they topped it up from Gibraltar Hospital with spirits of wine and camphor and myrrh, and that was lashed to the mainmast as the jury-rig Victory made its slow way home. He was put initially in a wooden coffin, which had been made from the mainmast of the French flagship L'Orient. Captain Ben Hallowell, a Canadian officer, one of his band of brothers, had the coffin made specially as a gift for Nelson, rather a macabre one, out of the mainmast fragments of L'Orient. And he always kept it, Nelson always kept it in his personal cabin. I remember as a child going to the United Services Museum and gazing with some amazement at a jar of the pickling fluid that had surrounded Nelson during his journey home. His coffin was then put in. He was then put in a lead-lined coffin, and then a fine ebony one, and the catafalque in the shape of a ship of war took his body to St Paul's Cathedral after its laying in state in Whitehall. On the 9th of January 1806, perhaps the largest crowd that had ever assembled in Britain attended London to be present and watch Nelson's funeral procession. No women were admitted to the funeral, which lasted 4 hours, and flags, Spanish and French captured flags, were draped around, and the coffin was eventually lowered into a sarcophagus made of stone that had been originally intended for Cardinal Wolsey, and he was laid to rest in St Paul's, where he lies today. So, ladies and gentlemen, we have Rear Admiral Lord Horatio Nelson, a man of intense naval integrity and spirit, a very brave man who probably died at the right time, because the scandal of his affair with Emma Hamilton would have caught up with him had he lived. And we have to remember it wasn't only Nelson that gained the sea power that Britain enjoyed, and enjoyed for long after this. It was many other matelots, marines, and fine commanders. But Nelson obviously is our great naval hero. And just to finish with, to show you the very first title page of the first edition, Volume 1, July 1913, of the British Journal of Surgery. And it's interesting that over half the men who were on the editorial committee went on to become very experienced war heroes in the calamity that followed in 1914 to 18. So on 21st of October this year, raise your glasses to our great hero, Lord Nelson. Thank you very much.